Thank you very much, Mr. Chairman. I think we have a lot of talk about pleural disease. Can this symposium encourage us to get or to have our guideline of treatment of pleural disease, especially pleural effusion, because before I entering this subject. However, for one or other reason, we add COPD to our symposium to see what's change of management in COPD patient. In the last gold guide 2024, حقيقة we have some changes, but not very dramatic changes. So by definition, the new definition of COPD now from since 2023, حقيقة it can become a chronic obstructive pulmonary disease is a heterogeneous, like in asthma, heterogeneous disease. While previously it's called a common preventable and treatable disease. It was more promising definition before. That treatable and prevention had been omitted. So is it preventable? And I think when we diagnose the case as early as possible, not in advance. Unfortunately, the great majority of our patients not diagnosed as early as possible. So return back to the definition. A chronic obstructive pulmonary disease is a heterogeneous condition characterized by chronic respiratory symptoms. And you know this is the definition of on a clinical aspect. It may be affecting the bronchioles, the bronchi, and alveoli in case of emphysema. Introduction, why we are considering is one of the important cause of chronic illness, because the global prevalence of COPD is reaching or exceeding 10%. You hope very high. COPD now is one of the third or top 3 cause of death worldwide. And 90% of death occur in a what's called low and middle income communities, countries, in our country especially. So it is at the time of possibly smoking had been seized or reduced in a developed country, in underdeveloping country and developing country, it will be increased. Unfortunately, this is the prevalence higher. COPD underdiagnosed, especially in our what is called LMIC countries, underdiagnosed. More than 3 million people died at 2019, primarily from COPD, because they may die, other died from other cardiovascular and something like malignancy, which is very high. Globally, the COPD burden is projected to increase in coming decade because of the continued exposure to the and aging population. The direct cost of COPD is European very high. It has been estimated in the European Union's more than 48 billion euro had been spent at 2011. And globally, it may be, the cost may be estimated that it may reach in 2050, it may be increase or approximately more than $4 trillion globally. So the huge burden. We have a new taxonomy in COPD in the last guideline, what is called genetically determined, which is mainly due to alpha antitrypsin, called COPD-G. And COPD due to abnormal lung development, like developmental and birth weight, and among those called D. COPD, environmental, cigarette smoking, or biomass, اللي حكى عليها دكتور. We have many cases biomass, especially in the rural area, and had been estimated that more than 3 million in African country or low economic, they have a biomass exposure and responsible for their التنور والحطب والهاي تعرفوها. It's maybe also another burden of environmental. It's called C and B. And COPD due to infection, which is tuberculosis in our countries, more prevalent and may lead to fibrotic changes and may end with the even cardiopulmonary and advanced COPD. And COPD and asthma is called COPD-A. يمكن overlapping syndrome بعد ما نستخدمها because of this new taxonomy. And COPD unknown cause remain. And COPD of young possibly اكو to add to the complexity. Clinical indicators of considering the diagnosis on a clinical ground, you know the story, and this the cardinal manifestation of disease here بالحقيقة dyspnea. But once the patient becomes dyspneic, unfortunately they have at least moderate to severe disease. So diagnosing of patient before dyspnea, I think we are more or less treat him as early as possible. Recurrent wheeze, chronic cough, recurrent lower respiratory tract, and history of risk factor اللي exposure اللي هي possibly the most important, cigarette smoking and biomass and other. Other causes of chronic cough, I used to simplify this. This is a very nice slide by the Gold, because I know that not everyone here is specialist in respiratory. Fortunately, and I'm very glad to see many undergraduate or postgraduate or internist to demonstrate this presentation. It may be like asthma, lung cancer, tuberculosis, bronchiectasis, the cardiac heart failure, interstitial, all may be different, should be differentiated, and a proper diagnosis of COPD is the first cornerstone for the proper management. COPD should be differentiated from other like asthma, you know, congestive heart failure, and both may be coexist in the same patient, because middle and all cases, smoker, ischemic heart disease more common. So we may have patient with labeled as heart failure and he may have COPD predominantly. So congestive heart failure, bronchiectasis, tuberculosis, and obliterative bronchiolitis, which is more common in children, and special what's called transplant patient. Diffuse bronchiolitis بالحقيقة fortunately it is not in our country. In the Far East شوفوا more common in male non-smoker, and they have diffuse disease that lead to obstructive airway disease. You know, you are familiar with the Gold previously. It's a simplified way of classifying the COPD according to mild, moderate, according to the BFT or just spirometric aspect. It helped to differentiate severity of disease, and you know the scaling of modified MRC dyspnea to clarify the symptom and severity of disease in any patient that have been diagnosed. Again, we have what is called CAT assessment can be applied, and by these parameters, you can evaluate the stage of disease, and according to this staging, we will adjust the patient for our treatment strategy and what is the best to start with the treatment from the beginning. So the last one, بالحقيقة 2023, they have omitting the C and D and replaced by what is called E. And depending on the acute exacerbation, once it is more than twice moderately severe or one life-threatening exacerbation per year, this is irrespective to the symptomatology, we classify the patient in a group E, that the management totally different from that. C had been omitted, وكأنه بقى D مكانها replaced by E. So you know that this parameter, we use it for severity and for spirometric evaluation of severity. Differential diagnosis should be differentiated from other disease, coexisting disease, comorbidities may all change the fate of the disease and progressiveness. So differential diagnosis should be from the beginning to differentiate, as I said, from cardiac, asthma, other pulmonary diseases. And also the patient with COPD should be evaluated for comorbidity and severity and for screening for cancer, because you know that COPD patients, they have more likely to have cancer than comparable smoker patient without COPD, and maybe the chance up to 4 to 5 times. So maybe his disease complicated by cancer. This is the review of any management for patient for stable by review symptoms, improve exercise tolerance, improve health status, and to prevent disease progression. From the management point of view, first, again, the first step هو have the definite diagnosis and the definite severity of disease, depending on symptoms, risk factors, spirometric. And according to the application of these parameters like gold and these scaling for dyspnea, you can review the symptom and adjust the patient and review every part of the system to see whether the patient have a stable condition despite your management, or he need to complete this program of treatment like symptom treatment, exacerbation prevention, smoking cessation, وهي تعرفون هذا is a cornerstone for success of vaccination. هواية مرضانا بالحقيقة they have little bit vaccinated. والvaccination هسه the program had been widening to 5 or 6 vaccine وتمام, including even simplex or يعني herpes simplex and something like even other virus. الكوفيد دخل بالمعمعة, ف vaccination is important to prevent recurrent attack and the burden of the disease. Like asthma, we every patient to be re-evaluated as a symptom and exacerbation, assess the technique of inhaler, whether, and you know that this is the most important part of control, like in asthma, is a useful and tolerance and adherence and the proper use of inhaler. And the great majority need a teaching and education for such point. Then adjustment of escalating, switching of inhaler. What has changed from 2022? As I said, when it become A, B, and E irrespective to the symptomatology, depending on the exacerbation. So the more important burden of patient with COPD هو the exacerbation. The frequent, the more the horrible for the patient. يمكن دكتور مضر راح يحكي على acute exacerbation, أنا هم شوية أركز عليها. Some slide I will remain to دكتورة هنا لأنكو تداخل, بس أنا أخذت منها الإذن to cover more subject, or any pitfall from my lecture, she will help me to cover that. So this is the change. According to the severity from 2022, we use that. In a patient with a bronchodilator, either LABA or LAMA. When a patient have more symptom, but less than one exacerbation, they can use both LAMA, LABA. The ICS, it is not initially recommended or encouraged in the treatment. And if the patient have more exacerbation, this irrespective of the symptom, we can use LABA, LAMA from the beginning. And we consider ICS when there is eosinophilia from the beginning, maybe triple therapy, despite the patient, even if he is mildly symptomatic. Again, this is the same, but demonstration. Triple therapy is recommended as initial therapy in a group E, as I said, patient with eosinophil above 300 initially. But I think this is statement cannot be considered in every patient, because if the patient have recurrent, from the previous or old treatment teaching, and if the patient have more than twice exacerbation per year, and the FEV1 below 50, the ICS found to reduce the exacerbation, irrespective to the eosinophilia. So this may be changeable, and those with frequent ICS to be added to triple therapy is more, as I will demonstrate, more beneficial for controlling patient and preventing exacerbation. This is a drug, and randomized control trial suggested triple or smoking cessation, the benefit, pulmonary rehabilitation, and you know that we are missing this important cycle. كم واحد يسوي له rehabilitation for our patient? We need to learn more about this figure. Long-term oxygen, and there is special indication for that. I will leave that to Dr. Hana, لأن هي راح تحكي على new changes. And from that, we can say ICS plus LABA is no longer recommended as an initial treatment for, however, triple therapy is preferred by where ICS is needed. You know, this is a symptom-related approach to treatment. When a patient predominant feature mark his dyspnea, you can use one of the bronchodilator, LABA or LAMA. You can combine them when the patient not improve, and consider switching inhaler advice and modality. In acute exacerbation per se, here, even I think it is the eosinophil above 100, but not above 300, you can use a triple therapy here. But we can upgrading the patient or reducing the IC inhibitor if the patient is controlled on this triple therapy to get rid the disadvantage of inhaled corticosteroid. And you know what is the disadvantage of long-standing corticosteroid. I will leave these for Dr. Hana كذلك because advanced هي الفيتشر. So ICS, there is many large studies suggesting the great majority of patients with COPD, they not needing corticosteroid, inhaled corticosteroid. خلاص وقتي لو بعد؟ ايه عارفين؟ بعدنا اكو اشياء مهمه فيها. اي بس where is my slide? So we prefer to use strongly recommended or in favor of corticosteroid use when, as I said, there is more than 2 exacerbation or 1 serious exacerbation per year. And when there is basically blood eosinophilia more than 300 and history of concomitant asthma, it is this is the green light for the corticosteroid. On the other hand, repeated pneumonia events, blood eosinophilia less than 100, history of mycobacterium, more than line because endemic area, مو بس mycobacterium.
أستاذ عبد الحميد, you have 5 minutes.
5 minutes. واخذت 5 دقائق من الدكتوره لين قالت ما يخالف. 10 minutes. It would be 10. So we are dealing or concentrating on acute exacerbation. Acute exacerbation is important, I think, even for life-threatening. 40 to 70% of COPD cost due to acute exacerbation. Summit study, a trial, shows that cardiovascular events was 4 times higher in the first month in patients with acute exacerbation. And it may continue up to 1 year twice, the cardiovascular events. So it is accelerate other comorbidity and cause of death. Exacerbation in another Danish study, XCOV, had similar result, 3.7 in 4 weeks. The risk may remain 2 times higher up to 1 year after acute exacerbation. So there is a great burden on the cardiovascular. And you know, the great majority of patients, either they die from cardiovascular or respiratory, which is maybe more to cardiovascular. The ethos and impact studies, they say both, they said triple therapy was superior to dual therapy, ICS LABA, LABA LAMA, but there is no IC LAMA in this dual therapy, both comparable with the exacerbation reduction. And then our aim to reduce exacerbation. So why? Do you think that preventing exacerbation in COPD patient improved survival? I think it is yes. دائما نقول what is improving survival? Oxygen, okay. Cigarette smoking, possibly rehabilitation, improve longevity, possibly not. But from this, reducing exacerbation may be improving other cause of death, reducing the mortality from other cause than this. So assessment of exacerbation by symptoms and assessment by evaluation of pulmonary function test. And I think this is a very nice slide for practical point, had been used to classify exacerbation according to severity. We have the mild, moderate, severe. Here they use what is called dyspnea visual analog scale of dyspnea, or what is called visual analog scoring of dyspnea. سامعين بيها؟ Yes. بالحقيقة simple حتى بها colored وبها parameter. When it is less than 5, respiratory rate less than 24, and possibly heart rate less than 95, and the saturation is more than 90, called mild. Why? For treatment strategy, can be treated as outpatient without harm. But in a very severe cases, dyspnea scale, heart rate, and of the same moderate, which is dyspnea scale more than 5, respiratory rate higher than 24, heart rate more than 95, would handle it, and the saturation persistently low. And the C-reactive protein also can be adapted for severity more than 10 milligram, and patient unstable or oxygen deteriorating. This is a patient with severe, which may need hospitalization, and even we may need intensive care. Potential indication for the hospitalization. We have many cases, patients have need acutely or critically ill, need hospitalization, and this is an indication. نعطيكم المحاضرة إذا تحبون بعدين. And indication for respiratory or medical intensive care when there is severe dyspnea that responding inadequately to emergency, patient disturbed level of consciousness, confusion, coma, or something like that, persistent worsening of hypoxemia, need for invasive mechanism, and hemodynamically unstable. This is intensive care indication. Indication for non-invasive, it is important because this is bridging and maybe preventing intubation and invasive, important indication. Indication for invasive mechanism, any patient not responding to non-invasive or deterioration of level of consciousness and stable, we can consider intubation. المشكلة هذا القرار, it is a bit difficult question. A patient with advanced COPD, many centers, they hit such patient because he may be difficult to wean and to be discharged to the healthy environment. Massive aspiration when there is other indication. So this is an indication for bronchodilator and our treatment. Common risk factor for the development of lung cancer, just to remind you that a patient above 55, smoking more than 30 packs per year, presence of emphysema by CT, increase the likelihood of having cancer, presence of airway limitation, and BMI lower than 25, family history of cancer, those patients should be, I think, evaluated for malignancy and screening for that. Vaccination, as I said, I think قصرين احنا وياهم ويا المرضى مو تمام. So influenza vaccine, COVID vaccine, pneumococcal vaccine, respiratory syncytial virus had been added, and even herpes zoster and whooping cough vaccine should be given to the patient. You know, influenza COVID يمكن annually, possibly, بينما pneumococcal, it may be lifelong vaccination should be considered to prevent catastrophic. Oxygen supplementation, you know this, it is a patient may be an advanced disease, they need oxygen when the saturation persistently low. يمكن the same of UK strategy of oxygen administration, provided the patient يشرطون انه يمكن اوكي to stop smoking. يعني شرط اساسي مو فلازم نخلي هالشرط احنا ماتين to stop smoking. Pulmonary rehabilitation on. Do you think we need أنا ترى أخذ 5 دقائق من ما يخالف. We need more parameter to get better prognostic evaluation. شو يقولون الإكسبرت؟ مثل الطيارة. The more بالحقيقة كم قائد الطيارة يشوفه كم أكو فد parameters يلا to can fly safely. A patient, I think, COPD, maybe the next program of treatment, maybe the next guideline, considering effectively the comorbidity to be introduced in there. Other can add to the taxonomy, can be COPD, atrial fibrillation, because they found the 5-year survival for patients with a chronic AF, which is so common in COPD due to many pathogenesis, it will be less than 50%. And again, COPD and OSA. Don't forget, many patients with COPD, they have OSA. There is what is called COPD OSA syndrome. I can add to the taxonomy اللي موجود to add this comorbidity because need a treatment of such. So COPD and other comorbidity, cardiovascular is the most or the major cause of death. COPD and pulmonary hypertension. Don't forget that. Patient dyspneic because the great majority of COPD, they have mild to moderate hypertension. Severe is fortunately unlikely, but when coexisting pulmonary hypertension, the strategy should be considered. Although there is no specific treatment for pulmonary hypertension secondary to COPD, but أكو challenging that BD5 inhibitors can be useful in certain individuals. Pulmonary hypertension and pulmonary COPD AF, COPD OSA possibly may be added to the comorbidity and treatment strategy of our group. Sorry for delay. بس لأن because I'm the first أخذت راحتي شوية على حساب
Thank you, Professor Abdul Hameed, for your informative summarization of what's new in Gold 2024.